So morning everybody. I feel again I've got that slot, follow that. I mean, what amazing stories. Thank you very, very much for sharing them. Incredibly inspiring and very humbling, and it puts us mere managers in our place. Anyway, I'm very pleased to be here. I'm Juliet Bouverie. I'm Director of Services and Influencing at Macmillan Cancer Support. And it's lovely to be here because I remember approving the business case for investment in Sheffield in this area 3 years ago. And I've kind of been following from the sidelines some of the individual projects. So I'm really looking forward to hearing a bit more about the progress of those projects, because the power is in joining those up and having a real impact across the whole population. And it's true to say that you are a very, very progressive area, and you're certainly leading the way in terms of what you're doing across England. So very, very well done. So I'm going to bring you up to date with all the latest evidence about the changing story of cancer and the unmet needs of people affected by cancer. I'm going to kind of reinforce the message about the case for change, how just carrying on as we are is not going to be good enough. I'm going to talk a little bit about Macmillan's role, what we know as some of the solutions, and I'm going to kind of leave you with a couple of challenges at the end that I think that we'll come back to through the day. And I make no apologies, but some of my messages will absolutely reinforce Jane Marr's earlier messages about the changing story of cancer. So we know the statistics. The good news is there's more people living longer with cancer, and that's in no small part thanks to advances in research and advances in treatment. We know there's 2.5 million people alive today with a cancer diagnosis. That's increased by 400,000 over the last 5 years. And we know that there's going to be at least 4 million people living with cancer by 2030. And when you look at the trends over the next 15 years, and you look at what we call the scarves, the greatest area where there's going to be the greatest proportional growth is actually in those two green blocks, which is people living with and beyond cancer. But in particular, we're starting to see a growth in the number of people who are diagnosed with advanced cancer, who know that they're going to die of cancer, but are still actually amenable to treatment. So you've got a growing cohort of people with advanced but treatable cancer who have quite particular needs. We know that median survival is improving all the time. So back in the 1970s, the median survival across all cancers was about 12 months. And we know now it's around 7 years, and that 50% of people in the UK today now survive at least 10 years. So that's the good news. But we know, as we've heard this morning, that everybody's experience of cancer is different. And we know there's over 200 different types of cancer, and actually median survival varies hugely depending on the type of cancer that you have. So we've got cancers like breast, where fortunately more women with cancer are living 10 years and beyond. We've got cancers like bowel and colorectal cancer, where people are maybe living 3-5 years, really having quite difficult experiences, relapse, remit, having to make some quite difficult decisions at points in their treatment. And then sadly, we have got those cancers that run along the bottom of this slide, where over the last kind of 30 years or so, there's been very little improvement in median survival. And the typical average median survival is less than 12 months. So that's the cancers like pancreatic cancer, brain cancer, sarcomas. So let's not go kidding ourselves that actually it's a good news story for everybody. And we in this room know that actually surviving cancer doesn't necessarily mean living well. We know there's 1 in 4 people who are dealing with the consequences of treatment. So we know that's 625,000 people who are struggling with some of the clinical effects of the treatment. And that actually what we know is that if earlier action, earlier advice, earlier intervention was given, some of the consequences of that treatment could either be prevented or could be ameliorated. And that we know 1 in 5 people have unmet needs. And that's not just unmet needs that are there maybe 6 months after treatment. Those are unmet needs that carry on. And we know that about 1 in 4 people say that they experience ongoing disability or ill health as a result of their cancer. These are some of the statistics that are contained in Macmillan's Consequences of Treatment report about those side effects of the treatment that I referred to. And they're really big numbers, aren't they? And they're really quite shocking because some of these consequences, as I said before, they can be ameliorated or prevented with the right advice prior to and at the point of treatment. We're understanding more about those consequences of treatment. We're understanding better how to reflect what people need to do in clinical guidelines. But there's a lot more for us to do to raise awareness and to make sure that clinicians and health professionals are having routine and early conversations with people about what action they can take to prevent these consequences of treatment. And we know, as we've heard before, that cancer doesn't just affect people's physical well-being. It also affects all other aspects of people's lives. It affects their emotions, their finances, and they have practical and personal support needs. So we know that 1 in 4 people tell us that they really do feel lonely and isolated as a consequence of having treatment. And we know it's particularly when people are discharged from active treatment, they're back at home, they're still struggling with the physical and emotional consequences of the treatment, they're not being followed up in primary care, people routinely report that they feel isolated and abandoned. We know very, very significant numbers worry about their finances and fall quite quickly into financial hardship. And we know that when you look at the cancer population compared to the general population, more people are struggling to stay at or return to work. And we know that 37% of people with cancer are more likely to be unemployed. Now, these statistics come from a report that Macmillan published only last month, in March. It's incredibly up-to-date data. And it's from a report called Hidden at Home. And it's a report that highlights the social care needs of people with cancer. So we've known for some time from stories and anecdotes that people have significant unmet social care needs as well as physical care needs. And this research report really brings that into sharp relief. And it shows us that 2/3 of people have unmet practical, personal, and emotional support needs. Almost 4 in 10 of those needs are classified as critical or substantial. And because quite a lot of those needs are going unrecognised and unmet, it's having a cost on the system. And what we know is that at least 15% of people are bouncing back into hospital for an unnecessary admission or an unnecessary visit to A&E, because some of those often quite basic but really significant practical and emotional support needs are going unaddressed. And from the research, which was with a big cohort of people with cancer and their carers, there were some really quite shocking statistics, like 1 in 10 people saying that they constantly or often felt housebound. That actually, because they didn't have the support to deal with their mobility needs, they were not actually able to leave the house, which kind of really brings into sharp relief the sense of isolation that many people are facing. We know, and Jane's already mentioned this, that people particularly struggle at the points of transition. And the annual Cancer Patient Experience Survey consistently tells us there are certain areas where people's needs continue to go unmet. So 40% of people not being told enough about side effects of treatment, 40% of people feeling that they're not given enough information about how to cope at home. Again, about 40% of people saying that they're not being given enough care from health and social care services when they're discharged from home. And we know it's not just people with cancer who are struggling. Let's not forget the carers of people with cancer. We know there's about 1.1 million carers of people with cancer. About 240,000 of those carers are actually performing healthcare tasks. And quite a number of them are doing it without adequate support, without adequate training. We know that only 5% of carers of people with cancer at the moment are getting a formal needs assessment. And so we're very proud that Macmillan, together with other charities, managed to get into the new Care Act that was launched on the 1st of April this year, statutory guidance that the NHS needs to formally identify carers and refer them to local authorities for a formal needs assessment, but it's just in the guidance. We've got a long way to go to make that happen. The other thing we also know, and this is a growing challenge for us, I think, within cancer, is people are not just living with cancer. They're also living with cancer and other comorbidities or other multi-morbidities. This is evidence that has come from the Scottish School of Primary Care. It dates back from 2012. And just last week, Macmillan published new up-to-date data on the proportion of people with cancer who are living with one or more other long-term condition. And the figures are big. So what we know is out of the 2.5 million people living with cancer today, 1.8 of them are living with cancer plus at least one other long-term condition. And a shocking 700,000 are living with cancer plus 3 or more long-term conditions. And this slide here tells you the most common conditions that people with cancer are experiencing at the moment. Probably no surprises to you, but the 3 most common are hypertension, obesity, and mental health. And the prevalence of cancer with other long-term conditions is only going to increase over the next 15 years. And that presents a challenge to us, because we talk about the importance of integrated care. Now, that's not just about integrating services and care around the needs of the person with their cancer, but it also requires us to integrate better across all long-term conditions and work more closely with other specialties. So, for example, oncologists need to start working more with geriatricians, and we need to make sure when we're talking about care planning that we're pushing for integrated care plans so that people don't have a care plan for their diabetes and a care plan for their cancer and a care plan for their dementia. And I think it really forces us to think differently and to look to develop new partnerships. The other challenge that we have in cancer is obviously we're dealing within a cash-constrained environment, and we know that failing to meet people's needs has cost implications. And this slide shows that over the last 5 years in England, hospital admissions for cancer have gone up by 100,000 cases a year. And we know from Macmillan's Roots from Diagnosis research that actually often for people who are living anywhere between 1 to 5 years who've got cancer and other long-term conditions, that the costs of their survivorship journey are very significant. So this research programme categorised 82,000 people with cancer into 8 different groups. And the groups in the middle, what you can see from the bar chart, is that actually the survivorship costs are greater than the treatment costs. So if we don't address people's unmet needs when they've left hospital and they're out of active treatment, there's a very significant cost to the system. We're going to have to cope with flat budgets over the next few years. We know that some of the current models of follow-up and care and support are not adequate to meet people's needs. So actually just kind of plugging the gaps and tinkering at the edges isn't enough. What we need is kind of radical, kind of whole system change. And that's what you've been doing in this area, is looking at what the systemic problems are and thinking about creative ways of addressing the problems. And there are kind of 3 areas where we really need to think and work radically differently. The first is around a kind of mindset change. And when we're talking to the converted here, we all know that people are living with and beyond cancer. We all understand the value of supporting people to get their lives back to a new sense of normality. We understand the importance of recovery and rehabilitation. Let's not go kidding ourselves. There's an awful lot of people out there who still have an outdated perception of cancer, who still think of it as being about cure or death, who still think it's really the sole preoccupation of hospitals. There's something really important for us to do about changing perceptions about cancer and changing perceptions about people with cancer, that actually people with cancer are experts by experience, they can and want to help themselves, and that actually it's vitally important. We need a change in ways of working, and we need a change in the way that we actually implement solutions, and we need a change in the way that we think about partnerships. So it's no longer enough just to think about partnering with hospitals and commissioners. We've got to think much more broadly about partnerships in terms of partnerships with local authorities, partnerships with other charities and organisations that work in long-term conditions, partnerships with employers, partnerships in the community, a lot of what Ali so eloquently touched on. And we've got to challenge ourselves to think differently. Now, there's lots of reasons for optimism. We know very well what good care and support looks and feels like. These are Macmillan's 9 outcomes, which I'm sure you will have seen before, but they came from extensive research and talking to people with cancer and their carers who told us that these are the things that really matter. It's about personalised care. You're way more than just your cancer. It's about you as a person. It's about knowing what you can do to help yourself. It's about optimising your quality of life. It's about living well and living well at home, not being ill in hospital. And it's all those things that we had up on that first vision slide at the beginning about optimising health, well-being, individual potential and aspirations. So we know what good looks like. Macmillan is a key partner in all of this. Our job is to make sure that we do reach and improve the lives of everyone living with cancer. But really importantly, we know we can't do it on our own. Everything that we do is about mobilising and inspiring others to work with us to adopt some of the solutions that we promote. And some of you may have seen this slide before, but this is a way that we describe Macmillan's role. Now, Macmillan is that tiny green dot down at the bottom. You probably can't even see it. And that represents the amount of money that we spend on cancer care each year, which this year will be 140 million, which sounds a lot, but you compare that to the middle blob, which is effectively the £7 billion that's spent on cancer, and you compare that to the £122 billion that's spent on health and social care, Macmillan is minute. So our job is to try and get our voice amplified and to make sure that as many of our solutions that we promote are adopted and mainstreamed not just in cancer, but also across the wider health and social care arena. So we know what good looks like, and actually we know a lot about the solutions. We know a lot about what works. So Jane referred to it earlier. We know that the single biggest thing that improves patient experience is access to a clinical nurse specialist that involve people like support workers or care coordinators and teams that recognise the value of volunteers, people like cancer buddies, people who've been through the experience before, who can play a really key part in meeting people's practical and emotional support needs. We know that physical activity, funnily enough, thank you Dot, is a really key solution. It's not expensive. It's something that people can actually do relatively easily, but we know there's not enough healthcare professionals who routinely talk to people affected by cancer about the benefits of physical activity. And physical activity doesn't necessarily mean climbing peaks. Actually, it can just be, 20 minutes of walking a day. Just doing kind of really quite basic, moderate physical activity can make a big difference. And Macmillan has published a number of evidence reviews around the benefits of physical activity. And the statistics are astounding. So if you take breast cancer, if you take 150 minutes of just moderate physical activity a week, it can reduce your risk of getting type 2 diabetes by anywhere between 30 to 40%. It can reduce your risk of cardiovascular disease by about 20%. It can reduce your risk of another cancer recurrence by anywhere between 30 to 40%, and it reduces mortality by the same amount. I mean, amazingly powerful statistics. These are not ones I'm making up. These are from real studies, real evidence. So the more that we can do to keep promoting the benefits of physical activity and healthy lifestyles and good diet and nutrition, the better. And we know, as Jane has already touched on, about the benefits of supporting people's recovery. And we know that taking a proactive approach to care and rehabilitation makes a real difference. We know that empowering patients to be involved as active partners in decisions about their treatment and care, supporting them to feel in control, makes a big difference. And things like the treatment summary, where actually a summary of somebody's treatment then goes to primary care, and this follow-up in primary care helps hugely in terms of the coordination of somebody's journey. And some of the data that we're getting on the value of the recovery package and the value of redesigning follow-up pathways so that those people who can self-manage are supported to do so, and the fact that that then frees up clinician time to concentrate on the people who've got the most complex needs. We're getting some good data, but it's local and it's patchy, but we have got data. And the electronic holistic needs assessment is a core kind of plank of the recovery package. And I mean, Jane referred to the fact that we're piloting the electronic holistic needs assessment in over 60 trusts at the moment. We've had 13,000 assessments completed, 10,000 care plans. So what we've now got is real-time, up-to-date data on what the top concerns are that people with cancer are articulating. And these are the top 5. And I'm sure there's absolutely no surprises for any of you in these. I mean, worry, anxiety, both about what does this mean for me in my life and, you know, am I at risk of a recurrence? That comes up as the number one consistent concern. But tiredness, fatigue, that comes up again consistently. And in the top 10, which isn't shown on these slides, is money worries, worries about staying out or returning to work, worries about what I can do in terms of maintaining a healthy diet. Now, what we know is that actually, quite often, it's the conversation about those concerns that just in itself makes a difference. It makes people feel listened to, it makes people feel supported. And some of the solutions to address anxiety or kind of tiredness problems, you know, they're not complex, expensive clinical solutions. Often they're just about having an opportunity to talk to people who've been through the same experience. Often it is about understanding the benefits of a healthy diet and keeping physically active. So we know a lot about what works. Now, I want to leave you with 2 challenges, both of which actually we've already touched on this morning. The first is about how we can take what we're learning in cancer and apply it to other long-term conditions, but also align what we're doing with actually the kind of language and models that are emerging from the long-term conditions agenda. So some of you may have seen this. This is NHS England's House of Care, which is actually built on exactly the same principles of the recovery package, where it's the person at the centre, and then you wrap the services and you wrap the commissioning structures around the needs of the individual. But we've been talking cancer recovery package. In parallel, the long-term conditions movement have been talking about the House of Care. It is vitally important that we start being able to express where cancer is similar to other long-term conditions and to start to be able to talk their language, because that's the way in which we're going to get traction with local authorities, with other people working in long-term conditions who we know need to see people with cancer as relevant to them. The second challenge that we absolutely have to address is the cost challenge. So I've referred to the cost of not addressing people's needs. The cost of doing nothing is very significant. But we also know that there is a cost associated with doing things differently, isn't there? Actually, just because people are so very, very busy, actually redesigning pathways, implementing the recovery package. And we know that we need investment in project management. We need investment in clinical nurse specialists, actually assessment and care planning. It needs the appropriate infrastructure in place. But we do know that if you invest up front, there is the potential for cost savings further down the line in terms of people not using health services unnecessarily, in terms of people being better able to support themselves and their needs being appropriately met. So I think one of the challenges that we have to address is getting a really clear narrative around actually the upfront investments that's required to make the change, but actually the downstream savings. Macmillan has recently commissioned a health economics evaluation of the recovery package, which we'll be reporting this autumn, that I think is going to give us some really useful data. So just the final thing I wanted to say is that now is a real time of opportunity for us. Many of you will know that we now have a commitment for an updated cancer strategy for England, which is fantastic news. I represent Macmillan on the Cancer Strategy Task Force. If I'm honest, it's a slightly daunting job because the Cancer Strategy Task Force is mostly made up of very eminent scientists, researchers, clinicians, and I'm there speaking up for people with cancer, speaking up for patients, for carers, promoting the importance of good patient experience, good quality of life, and good experience for people at end-of-life care. But we have a very significant opportunity through the cancer strategy to change people's mindsets and to get some of the solutions that we know work reflected in that strategy document. It's going to be published towards the end of June, and the rationale for that is that hopefully what it will do is help to influence the comprehensive spending review and the amount of money that is allocated to cancer as part of the health budget. And we are pushing a very strong message that we're going to need more investment, that actually coping within the financial envelope that we have today is not going to be enough. So it's a great opportunity for us, and rest assured I'm there really pushing the importance of the Living With and Beyond cancer agenda. So thank you all very much.